Welcome to This Explainer. Today we're going to break down the critical clinical reasoning skills you need to recognize and respond to pediatric maltreatment. Honestly, this is one of the absolutely most vital responsibilities you're ever going to hold as a healthcare provider. We're going to look strictly at the objective clinical evidence, pulling directly from our foundational nursing guidelines to equip you with exactly what you need to know to keep your patients safe. Let's get right into it.
First things first, we've got to completely dismantle our biases. Maltreatment doesn't look a certain way, and it certainly doesn't only happen in certain neighborhoods. If you allow demographic assumptions like income, education, or appearance to raise or lower your clinical suspicion, you are applying the wrong evidence entirely. Relying on stereotypes instead of objective clinical evidence can severely compromise patient safety. At the end of the day, the objective clinical picture is the only thing that matters.
Here is our agenda for today. 1. Foundations of child maltreatment. 2. Recognizing the 4 types. 3. Injury patterns and red flags. 4. Abusive head trauma. And 5. The nursing priority sequence.
Section 1. Foundations of child maltreatment.
Now, it's definitely important to understand the environment a child lives in. Factors like chronic stress, divorce, poverty, inadequate housing, or substance use are recognized risk indicators. However, they do not prove abuse occurred. A single missed appointment, one dirty outfit, or just living in poverty does not automatically establish neglect. Your objective assessment, what you can actually see, measure, and document on the child's body and in their behavior, that is the true foundation of your clinical reasoning.
Section 2. Recognizing the 4 types.
When we talk about maltreatment, we're really looking at 4 main categories that encompass a broad range of harm. Physical abuse involves causing direct pain or injury. Sexual abuse involves any sexual contact without valid consent, and yes, this absolutely includes dating violence among adolescents. Emotional abuse is all about intimidating or minimizing a child's self-worth. And neglect? That's the failure to provide basic physical needs like food, shelter, and medical care, or the failure to provide emotional nurturing and safety. This next point is absolutely crucial. We cannot dismiss emotional abuse or neglect simply because there isn't a visible physical injury. Emotional abuse leaves no physical bruise, but its clinical findings are profound. Behavioral findings like severe withdrawal, eating disorders, sleep disturbances, anxiety, or suicide attempts require urgent evaluation. If a child makes suicidal statements, they need immediate mental health support and supervision. These signs are literally just as critical as a broken bone.
Section 3. Injury patterns and red flags.
So what are the physical red flags we need to look out for? For bruising, if you see bruises on an infant younger than 6 months who isn't even crawling yet, that is highly suspicious. Bruises shaped like a belt buckle or some kind of implement are also major warning signs. For fractures, seeing multiple fractures in different stages of healing or spiral fractures in the forearm caused by forceful twisting, those should immediately raise your concern. And for burns, pay really close attention to symmetrical glove or stocking distributions on the hands or feet. That suggests forced immersion in hot water. Also watch out for small round burns that indicate a lit cigarette. What it all comes down to is comparing the caregiver's story to the science. We call this developmental plausibility. Always compare the caregiver's explanation with the child's actual developmental ability. If a caregiver claims a 3-month-old infant rolled off a high surface, but that infant doesn't even have the motor skills to roll over yet, well, that mechanism is developmentally implausible. Any inconsistent or changing explanation for a patterned injury warrants immediate further evaluation. But here's where your clinical thinking really gets put to the test. While multiple fractures in different healing stages are a massive red flag, we can't just jump to premature conclusions. Conditions like osteogenesis imperfecta, a genetic collagen disorder that causes bone fragility, can also cause recurrent fractures. You might notice a family history of the condition or perhaps blue sclera in the child's eyes. You have to differentiate between genetic bone fragility and actual maltreatment. You do this by completing a careful, objective assessment. Don't automatically assume abuse, but never dismiss the possibility either.
Section 4. Abusive head trauma.
Okay, this next point is arguably one of the most critical takeaways from our source material today. Abusive head trauma, often known as shaken baby syndrome, occurs when forceful shaking causes an intracranial hemorrhage. And the chilling reality here, this can present without a single visible bruise or scratch on the child's body. A lack of external injury absolutely does not rule out serious internal, life-threatening harm.
Because those external injuries might be completely absent, you've got to urgently assess for internal neurologic signs. If an infant presents with unexplained vomiting, poor feeding, severe lethargy, a bulging fontanelle, or sudden seizure activity, you must recognize these as signs of increased intracranial pressure. A child with these symptoms can deteriorate incredibly fast. Recognizing these subtle, internal warning signs is literally a matter of life and death.
Section 5. The nursing priority sequence.
So how do we actually respond? This is your immediate priority sequence. And trust me, the order matters. You must always stabilize medical life threats first. If a child comes in with suspected abuse of head trauma and apnea, you don't stop to conduct a lengthy interview or fill out a report. No way. You secure their airway, breathing, and circulation first. Only after stabilization does your priority shift to ensuring the child is safe from further harm, followed by conducting a full assessment, rigorous documentation, and finally, mandatory reporting.
When you finally reach the documentation phase, you've got to strip away all emotion and judgment. You are recording facts, not verdicts. Avoid writing conclusive statements like, "the parent is lying." Instead, you want to use objective, measurable language. Write things like, "the caregiver's explanation changed during the interview," or "the bruise measured 3 centimeters and was shaped like a buckle." Use body diagrams and exact quotes. Your objective documentation is absolutely vital for the child's ongoing protection.
During your assessment, therapeutic interviewing is key. You have to interview the child and the caregivers separately. Use open-ended questions like, "Tell me what happened." Why? Because asking leading questions or repeatedly probing a child can actually plant details in their mind rather than eliciting their own true memory. That can seriously compromise both the child's well-being and the reliability of the information. And crucially, never confront the caregiver or try to independently determine guilt. That is just not your role.
Which brings us to a massive safety alert. Remember, you are a healthcare provider. You're not a criminal investigator. Your legal and ethical mandate is to report suspected abuse to Child Protective Services. Mandatory reporting is based on reasonable suspicion alone. Proof is never, ever required before making that call. You don't wait for a confession. You don't gather forensic evidence to build a case. If your objective clinical assessment raises suspicion, you are obligated to report it to ensure the child is placed in a safe environment.
As we wrap up this explainer, I want to leave you with a vital question to ask yourself. If the story doesn't match the science, if the injury doesn't match the child's developmental ability, are you prepared to act? Are you prepared to stabilize the patient first, trust your objective assessment over any demographic biases, document the facts without judgment, and make the courageous call to report your suspicion? Because that objective clinical reasoning is exactly what will ultimately save a child's life.